Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have a 16-year-old female brought to the emergency department for shortness of breath and asthma exacerbation. She developed sudden shortness of breath and wheezing after running the mile in gym. She has taken several puffs of her albuterol, but it does not seem to be helping. Past medical history: she has had a normal birth history. She has had several ED visits and hospitalizations for her asthma, including PICU admissions. She has never been intubated. She has been diagnosed with moderate persistent asthma and has had 3 courses of oral steroids in the past 6 months. The asthma has been more difficult to control in the past year. She is followed by an allergist. Her medications include albuterol as needed, which she has been using daily for the past few months. Her daily control of medications include a combination of fluticasone and salmeterol, montelukast, and Claritin. She has no known drug allergies, and immunizations are up to date. Social history: she denies high-risk situations or behaviors. She lives with her parents. She has 2 younger siblings. She gets along well with her parents and siblings. They have a dog, and there are no smokers in the home. She's a straight A student, plays volleyball and softball. She's vice president of the student council, and she wants to be an orthopedic surgeon when she grows up. Family history includes her sister also having asthma. On physical exam, her temperature is 36.5, heart rate is 96, respiratory rate of 28, and blood pressure of 100/60. Her O2 sat is 98% on room air. Her height is 5 foot 7 inches, and her weight is 59 kilograms. In general, she is alert and awake. Initially, she's smiling, but now becoming slightly anxious. She's beginning to develop audible stridor and wheezing. Skin: there are no rashes, no lesions. HENT is essentially normal, with the tonsils being 2+, but no erythema. Neck is normal. Lung exam: there are audible inspiratory stridor and questionable expiratory wheezing. You notice suprasternal retractions, and there is decreased air entry. She is unable to finish complete sentences. Cardiac: she has normal rate and rhythm with normal S1, S2, and no murmurs. Abdomen is benign. Extremities: there is no clubbing, no cyanosis, no edema, and joints are normal with full range of motion. And neuro exam is normal as well. To summarize our problem list, we have a 16-year-old female coming in with shortness of breath and respiratory distress. She has inspiratory stridor and expiratory wheezing. She has a history of moderate persistent asthma with multiple ED visits and hospitalizations, including PICU admissions, and she has poorly controlled asthma. So in this case, we have a 16-year-old female coming in with acute stridor and wheezing. She has a history of asthma that seems to be getting worse over the last year, and it's not really responding to daily control of medications. So let's go through a differential diagnosis of a 16-year-old girl with acute stridor and wheezing and think about what might be happening with this patient. So given her history of asthma, one of the first things you have to think about on the differential is obviously an asthma exacerbation. So that could be what is going on given her history of asthma. So she could have acute exacerbation of her asthma, giving her the wheezing and maybe even the stridor. Other things on the differential, other than asthma exacerbation, include having something simple like croup. She could have a viral infection that is triggering the stridor and the croup, and that could be giving her the sudden onset of stridor and wheezing. Another entity, this again is more likely to be viral, but then there's something else called spasmodic croup that also can be sudden onset of inspiratory stridor. that you have to consider. So spasmodic croup is a sudden acute onset of inspiratory stridor, and it's usually related to some sort of trigger, some sort of allergen or an inhalant or something that triggers some laryngospasm and causes you to have this spasmodic croup. So she could have croup from a viral process, a viral infection, or she could have spasmodic croup from some sort of allergen that is causing this as well. And again, if she's being exposed to some sort of allergen, she could have some angioedema and anaphylaxis, angioedema or anaphylaxis, and that can cause you to have sudden onset of stridor and wheezing. So if she is atopic, has a history of allergies, which she does, she could be at risk of having some sort of anaphylaxis or angioedema secondary to some sort of trigger and some sort of allergen that she is exposed to. So that's another possibility as well then. Other things that you might consider are related to the vocal cord. So she could have something called vocal cord, just like vocal cord paralysis. So she is not able to move her vocal cords appropriately and has paralysis. Now usually that is after some sort of trauma or some sort of surgery, or sometimes like right after birth. She can have some injury, so it'd be unusual to present acutely at this age to have vocal cord paralysis. Again, if she had surgery or trauma and she had some damage to the recurrent laryngeal nerve, that can cause you to have vocal cord paralysis, or birth trauma and stretching of the neck can do that as well. Also other entities include subglottic stenosis that can give you acute onset of kind of stridor and or wheezing. So subglottic stenosis. Subglottic stenosis can be acquired or it could be congenital. So acquired subglottic stenosis, the most common cause is trauma from like intubation that can cause acquired subglottic stenosis. But then it could also be congenital. You could be born with it, or again be intubated as a neonate, and that could cause subglottic stenosis as well. So that's another consideration for causes of stridor and or wheezing. And we mentioned vocal cord paralysis, and then there's something called vocal cord dysfunction. So that's an entity that nowadays a lot of people will describe this more, instead of vocal cord dysfunction, they call it vocal cord. Instead of vocal cord dysfunction, they call it paradoxical vocal cord motion. So they call it paradoxical vocal cord motion is a newer term, or vocal cord dysfunction as I'm used to calling it. But nowadays, again, more recent literature suggests it as paradoxical vocal cord motion, and that actually helps understand what's happening in vocal cord dysfunction or the paradoxical vocal cord motion. And in that, what's happening is that the vocal cords, when you take a breath in and you inspire, usually the vocal cords will open to allow air to get in. But in this entity, they paradoxically, the vocal cords close on inspiration. So instead of abducting, AB abduct, which is a normal process when you inspire and take a breath in this entity, when you take a breath in, the vocal cords paradoxically adduct, AD, adduct, and close, and narrow the glottic opening, and that can cause stridor as well. So vocal cord dysfunction or paradoxical vocal cord motion is another entity that can cause you to have stridor and wheezing as well. Other things that are on the differential could include gastroesophageal reflux. So bad reflux can give you stridor and noisy breathing and sometimes respiratory type of symptoms as well. So GERD is on the differential for that as well. And then some sort of foreign body, either ingestion or aspiration. So if you aspirated a foreign body into your trachea, into your airway, that obviously would give you acute onset of wheezing and stridor. Or you can have a foreign body that is ingested and it's in your esophagus, and that's causing external compression onto the trachea and causing you to have some stridor or wheezing based on that then. So a foreign body ingestion or a foreign body aspiration is another consideration, especially in younger kids, like infants and toddlers and things. That's something to consider with acute onset of like stridor and wheezing and respiratory symptoms is another consideration as well then. And then a few other type of things. TE fistula would be another consideration. So if you have an H-type TE fistula, and then you're aspirating and causing you to have recurrent respiratory symptoms. The H-type TE fistula can sometimes cause you to have recurrent wheezing and respiratory distress and breathing type of issues as well. And then a few other entities. You can have polyps on your vocal cord, so vocal cord polyps can also cause you to have stridor and wheezing, so that can cause you to have respiratory distress and these type of symptoms as well. And then in younger kids, especially in infants and babies, you have to think about the different type of malasias, right? So there's laryngomalacia, there's tracheomalacia, there's bronchomalacia. So basically with malacia, laryngomalacia was the most common causes of inspiratory stridor in infants, where basically you have a floppy airway, and when you take a deep breath and you breathe in, that airway collapses in the area of the malacia, and infants will many times present with stridor and noisy breathing. So laryngomalacia or laryngotracheomalacia is a common cause of stridor and chronic stridor and recurrent stridor in infants, and they can be born with it, and then when they are crying and generating negative intrathoracic pressure, it can be worse. When they're sucking on a bottle and again generating more intrathoracic pressure, then it's worse. And when they're lying in the supine position, it can be worse as well, because then as they lay back, then the airway is a little more floppy. So laryngotracheomalacia in infants is a common cause of stridor and noisy breathing. They usually outgrow it by around 9 to 12 months of age, and you don't really need to do anything for it. On laryngoscopy, you could see the airway being floppy, and you could see it closing on inspiration. And they usually outgrow it, and then putting them in the prone position can help with some of the symptoms as well. And anytime they get a viral infection and mucus production and edema with croup or anything like that, then they have really exaggerated type of respiratory distress because of the underlying malacia that they have. So that's something to consider as well. Then, so these are some of the things that you have to consider for the differential diagnosis. And then the next kind of category of things you have to consider is going to be basically some sort of airway compression, some sort of extrinsic airway compression causing the respiratory distress and the wheezing and the stridor. So extrinsic airway compression can also cause the stridor and wheezing. So let's think about some entities that might cause that. So if you have extrinsic airway compression causing the wheezing and stridor, so let's think about some of those entities, right? So extrinsic airway compression. So some of the things that can cause that, you can have a subglottic hemangioma. So subglottic hemangioma. So it's possible that especially an infant coming in with the respiratory symptoms, if they have cutaneous hemangiomas, they can actually have a subglottic hemangioma, and then as the cutaneous hemangiomas are getting bigger in the first few months of life, in the first 9 to 12 months of life, a subglottic hemangioma can also be getting bigger as well, and that can cause airway compression and stridor or wheezing then. Another entity is going to be a vascular ring. So if you have a vascular ring or sling, that can also cause compression of the airway and cause stridor and wheezing. So this vascular ring or vascular sling, you have basically a blood vessel that comes wrapping around the esophagus and the trachea and causes external compression of the airway. So a vascular ring or sling. A lot of times in these infants, they will present sometimes a little bit younger in life. Sometimes it can be later on as well. But they could be minimally symptomatic and then present later in life. An interesting finding sometimes is going to be if you have a right-sided aortic arch on a chest X-ray. So sometimes it's incidentally found when somebody finally gets an X-ray for whatever reason because they have chronic respiratory symptoms and chronic wheezing and asthma. They get a chest X-ray and they're found to have a right-sided aortic arch, and that actually could be an indication that they have a vascular ring or a sling. So that's another entity that can cause extrinsic airway compression. And then there's different tumors that you have to think about as well that again might be in the mediastinal area that can cause external compression of the airway. So in older kids like her age, lymphoma is a consideration that can cause you to have a mediastinal mass and then come in with external compression of the airway. So that's also a possibility. And then in younger kids, a neuroblastoma is another type of tumor that can present with a posterior mediastinal mass in a 2-year-old, 3-year-old child coming in with wheezing and respiratory symptoms and stridor, and they actually might have external compression of the airway from something like a neuroblastoma then. So these are some of the things that we need to consider on this patient. This 16-year-old girl coming in with sudden onset of stridor and wheezing. I think asthma is always high in the differential, but then some of the other things have to be considered as well. So let's see how this case unfolds. So this patient received albuterol nebulizer treatments and did not respond, did not get any better. Continued to have the respiratory distress, continued to have the stridor and the wheezing. The patient also got a trial of racemic epinephrine to help her with her respiratory stridor. That did not seem to really make a difference or help that much as well. And she would have episodes where it got worse and it got better. So we had our pulmonologist take a look at her, and the pulmonologist ordered a pulmonary function test. A flow volume loop was done through the pulmonary function test. So we can just briefly talk about that. So let's see if we have a flow volume loop. So a typical flow volume loop. So on the y-axis is flow and on the x-axis is volume. So typically when you do this, you have the inspiratory phase, and then you have the expiratory phase, and that's typically what a flow volume loop would look like. So a normal flow volume loop, so this is inspiration and this is expiration. And in different disease processes, you can see different changes in flow volume loop curve. So typically in asthma, you will have it's an obstructive type of process, so it will affect expiration. So typically what you see on the flow volume loop is when you have asthma, you have a little bit of concavity in the expiratory phase of the flow volume loop. So typically the curve will be out here. But then when you have asthma and when you have an obstructive type of process on expiration, the curve and the loop will become a little bit more concave like this then. And then when you have an inspiratory type of process, and you have an a supraglottic or extra thoracic type of obstruction, that will then usually change your inspiratory portion of the loop because you have trouble getting air in, because you have the extrathoracic obstructive type of process. So then what happens with that type of process is that the inspiratory portion will be a little bit raised because you're not able to move air as well on the inspiratory phase. So that's what happened then. So this would be more with asthma and an obstructive type of process, and then this would be more when you have some sort of extrathoracic type of obstruction, so some sort of subglottic stenosis or something with like croup or something with your vocal cords that will usually affect the inspiratory portion of the loop, and it will cause an obstruction in the extrathoracic portion of the airway, and then your flow volume loop, the inspiratory portion will not be as deep then. So our patient had a flow volume loop, had PFTs that were done, and she actually showed a reduction of the inspiratory portion of the flow volume loop. So based on that, we suspected she had some sort of extrathoracic type of process that was causing obstruction on inspiration. So then the pulmonologist did a laryngoscopy, and the laryngoscopy on this patient was confirmatory of the diagnosis of vocal cord dysfunction or paroxysmal vocal cord motion. So the pulmonologist was able to see on inspiration that the vocal cords were actually closing on inspiration paradoxically, which again, they should be opening on inspiration, but they were closing paradoxically on inspiration, and that was causing the extrathoracic obstruction and causing inspiratory stridor in this 16-year-old girl. And she then, based on the flow volume loop and based on the laryngoscopy, was diagnosed with vocal cord dysfunction or paradoxical vocal cord motion as her final diagnosis then. So let's briefly talk about vocal cord dysfunction or paroxysmal vocal cord motion, the diagnosis that our patient had. So this entity is commonly diagnosed in adolescents. The incidence is higher in female adolescents, and typically they'll have a history of very sudden onset of respiratory distress and respiratory symptoms, a very sudden onset of inspiratory stridor or expiratory wheezing, and basically they feel like they can't move air because their airway is closing and their vocal cords are closing on inspiration, so they have trouble moving air and they have this sense of respiratory distress and symptoms. And many times it's mistakenly diagnosed as asthma because they come in very acutely with wheezing and stridor, and they get treated for asthma. They're on multiple controller medications and steroids, and are being labeled as persistent asthma and difficult to control asthma, when in fact they might not have asthma. Now, some studies indicate that up to 50% of patients with paroxysmal vocal cord motion can have asthma, so you have to make sure that they don't have a concurrent diagnosis of asthma as well. But many times they don't have asthma and they are being misdiagnosed as asthma when in fact they have this vocal cord dysfunction or the paroxysmal vocal cord motion. So once you made the diagnosis, first of all, you can kind of suspect it based on the demographics of a patient as well. So in adolescents, female patients, typically you get a history of these patients. They might have other issues like they might have like anxiety and stress can really bring out the symptoms as well. So they might start having these symptoms when they're really stressed out or when they're really anxious, which actually happened in this particular patient. If you remember from the history in the exam, is that when the team went in to see her, she was calm, but then as the team went in and started talking with her, she got more anxious and she started to develop respiratory symptoms and inspiratory stridor. So sometimes it can be induced with a stressful situation or an anxiety-provoking situation, which happened in this patient. So that helped us suspect that diagnosis in the patient. Also in the history, you'll get the history that these patients are very are very smart and they do very well in school. Like in this patient, this girl, she was a straight A student. She was captain of her volleyball team. She was vice president of her class, and she already had her life planned out. She wanted to go to medical school. She wanted to be an orthopedic surgeon. So a lot of times, type A personalities, the ones that are typically going to medical school and becoming physicians, might be at increased risk of this type of entity. And there's usually kind of high-strung type of individuals, type A personality, but then extra stressors and anxiety can sometimes really bring on some of these type of symptoms. So I think that's something to consider. As I was mentioning about asthma, you do need to differentiate this from asthma. Typically, vocal cord dysfunction is much more acute onset. It's usually more inspiratory stridor versus asthma. It might not be that acute. It can take a little bit of time to develop, and that's usually more expiratory wheezing. And asthma typically will respond to bronchodilators, and this entity usually does not respond to bronchodilators. So those are some of the things that you want to keep in mind to help you differentiate. And then the flow volume loop can help differentiate that as well, because if you have an obstructive process on expiration, then you'll see this concave portion of the curve. So that can help determine and help you distinguish between asthma or the paroxysmal vocal cord motion. The treatment for this is actually more behavioral. So there's really no medications. There's some suggestion that maybe Heliox and maybe even CPAP, if they're having a lot of trouble, can help. But usually it's just behavioral modification and trying to calm them down, trying to reduce the stress and underlying triggers that might induce the stress or might be inducing the anxiety. So it's trying to help them with from that perspective. Many times we will refer to a speech therapist to help with this process as well. The speech therapist can really help with kind of breathing techniques and get them to focus on their breathing and kind of focus on the different type of breathing techniques. So speech therapy can be effective, and then a psychologist or a therapist in counseling might be helpful as well to understand the underlying issues that are causing the stress and causing the anxiety that might be provoking some of these type of symptoms. So that's some of the things you want to consider for vocal cord dysfunction or paroxysmal vocal cord motion. So this is the differential diagnosis of this 16-year-old adolescent female coming in with acute onset of stridor and wheezing. Some of the things that you have to consider on the differential diagnosis. And then again, you can use this case to read about more of these individual entities and read around the case to improve your knowledge base. So hopefully this crash case was helpful to you, and the differential and the approach to this patient, and the discussion that we just had on paroxysmal vocal cord motion. Hopefully that was all helpful for you, and I look forward to seeing you in our future crash cases.